my honor to introduce Terry Peabody to speak to us today on educating the next generation of orthopedic surgeons. And to the majority of us here, we've known Terry for some time. I don't really have enough time to go over all of his vitae, but he's an Orange County boy, and he wore the black of Servite and the red of modern day in his history. He went to UC Irvine, undergrad and medical school and residency. He did a fellowship at University of Chicago in orthopedic oncology. And really as I looked at his CV, his professional career has been very consistently involved in his pursuits, especially of oncology, as well as education. And he is presently the Edwin Ryerson Professor of Orthopedic Surgery at Northwestern and Chairman of the Department of Orthopedic Surgery at Northwestern. He has characterized himself significantly in the whole orthopedic world. He's been a member of the American Orthopedic Association for 20 years. And briefly, he has 64 peer-reviewed articles, 14 non-peer-reviewed articles, 44 abstracts, 21 book chapters, 89 international presentations. And he's been visiting professor or guest speaker, as he's doing today, on multiple occasions. He's got fellowship-trained oncological orthopedic surgeons all over the country and the world. He's been a reviewer in multiple capacities. He's been involved in the ACGME. He's been intimately involved in the education of orthopedic surgeons in their residency. But the best part is that he's a human being. We all know him. He's got his great big 2 feet right on the ground, connected to Mother Earth. And it's a great combination to have. And we've included a bunch of people on this email so they can come and enjoy this discussion. From Terry. Terry, welcome. It's really good to see you. I'm glad we were able to chat a little bit. I'm going to go on mute and listen in.
Thank you so much. That's really a nice welcome. I'm sorry I'm not there in person. It'd be nice to be home, but it is what it is. But thank you so much. I'm going to talk today about education, and it may not be important to everybody, but it sort of is. So these are your partners that you're going to be hiring and people are going to be working with. And as I get older, it's also going to be the people actually operating on you in the future. So it is important. So we'll go through that. I want to thank these 2 gentlemen. On the left is Vance. He took me to my first Orthopedic Research Society meeting in Atlanta. He nearly got me killed, but it was a great meeting, and most appreciative of Vance for everything he did for me academically. He got me going, working together at UCI when I was a resident, so thank you, Vance. And to the right, Carlos, who's been a role for me, mentor to me throughout my career, through high school actually, through college, and then in practice. So thank you very much for the invitation. I'm happy to be here. I couldn't leave this without one extra acknowledgement here, and a picture tells 1,000 words. I can guarantee you there was no shorts like that being worn when he was a resident. So I'm so proud to see Bob doing well there in Newport Beach. I think he got his shorts from Dr. Baird, maybe. I'm not quite sure, but we'll see how that goes. But thank you, Bob, for all your help too. I'm going to share with you too some people that have played an important role in my life, and certainly I hold out as premier educators. Most of you from UCI know these people. Dr. Hoffer was my chairman. Next to him is Dr. Mike Simon, who was both a friend and mentor and leader for many years. You all know Bill McMaster and J.P. Connolly, Bert Mooney, Marianne Keenan down the lower right. And this year we were really happy that we could acknowledge Jackie Perry. She's the first female AOA pillar. So that was announced this year, and it was really a great thing. She was a great teacher. You know, by circumstance, I got to spend 14 months with her, so it was a terrific time. But I am the product of some really good educators in the past. So let me start by saying, you know, we've got the best job in the world. I don't think there's any question about that. We have very high job satisfaction. Every survey shows that. We are, if you mention you're an orthopedic surgeon, those of you who don't think you're your podiatrist, they hold you out to great respect. People really respect orthopedic surgeons. We make a very good living. There's very few of us begging for food, except for Dr. Pablo Criado, who used to hold that sign up. We have tremendously good colleagues, which is the reason why I got into this field and why many of us got into it. And by and large, we have very grateful patients. But a lot of satisfaction I get is from teaching sort of the next generation of people to come up. So let me move on. What has changed, though, is, orthopedic residency education did not have any of these words when I was a resident. So we didn't know anything about competencies, milestones, curriculum, any of this stuff. So we're going to talk about these and how these things have sort of driven change and how we train a resident now or educate a resident now. Disclosure, I'm a member of the board. I've got another year on the ABOS. These are all the members of the American Board of Orthopedic Surgeons. They're all practicing surgeons except for the one public member. And many of the faces there. It's been a great group. And it's been a tremendous honor, probably the best honor I've had in my professional career to be a member of the board. So with that disclosure, I'm going to give you some others. So first, I'm a dinosaur. You have to admit that as soon as you finish your training that you're a dinosaur. I filled out my medical school applications on a typewriter, okay, and that was while listening to an 8-track player. So I'm a senior generation now, believe it or not. I'm in my last quarter, and so a lot of the things I say, you're going to have to take with a grain of salt. My evaluations when I was a resident, I remember each and every one of these. Quit using your hands, Peabody. Butchers use their hands. You are goofing. The word's 4 letters, but I'll substitute goofing up my operation. That was Dr. Ewald at St. Joe's. I was wondering when you're going to bring that up. That was Dr. Hoffer. And then not bad for a guy whose hands are made of cement. So I don't recall ever getting a written evaluation as a resident. I was written up mostly by the nurses in chalk, but I never remember getting a written evaluation. My supervision guideline from Dr. White was this: feel free to call, but remember, calling is a sign of weakness. So this was the supervision guideline. And my evaluation of the faculty was this graduation skit, which was sort of a slap on the way out. Usually ended up a similar picture to the Red Wedding in Game of Thrones, those of you familiar with. So it was sort of a bloody affair, not very positive and not very anything you could build on. So our competencies as residents: keep any bad news away from the chief, don't goof things up, and take pride in doing a good job and learning something. So that last one remains true throughout everyone's career, but the first two have fallen away a little bit. How did we get there? What were the means that we got this education? Well, experiential learning is what we did. So we were there a long time. You went to different places that gave you different experiences, but there was no limit on the amount of time you spent there. So just by being there, you absorbed enough to be competent by the time you finished. We liken this a little bit to a teabag principle of education, where if you're placed in hot water for 5 years, when you finish, you're probably a good cup of tea, probably. But there's no sort of assessment of how you're doing along the way. We depended a lot on peer education, in other words, residents teaching residents. There was rigorous review. You were challenged, sometimes humiliated in the mornings on how you did things. There was graduated responsibility, oftentimes very quick. Sometimes you're over your head. But more than anything, there was a tolerance of error. People would allow learners to make mistakes, and you learned a lot by making mistakes. That's probably the biggest thing that has changed. The outcome by and large is competent surgeons. We don't have a problem, I would say nationally, with incompetent surgeons, at least not technically. Most of our problems are behavioral, and we're going to talk about that a little bit towards the end of the talk. But that system worked. It really did work, and it worked well by and large. So why change? Who makes the rules? These are the two official governing bodies of residency education and fellowship education, the ACGME and the ABOS. And I'm going to go through each, but there's been some other parties sort of become involved. One is the IOM, which is commissioned by Congress. They're usually set upon to address certain challenges that have come up, with or without real data to support it, as any government report would be. Especially societies. they've harbored a bit of influence, mostly on the fellowship side, I would say. And then the American College of Surgeons like to jump in and come up with policies to govern education, even though most orthopedics are not in the American College of Surgeons. The ACGME, the Accreditation Council, is a residency-directed organization. It accredits residencies, not individuals. It's not a government entity. It is charged only with determining the adequacy of education and the resources. It does not fund residencies. It doesn't consider impact on workforce. And it is set up to reassure the public that the training program is sufficient to educate residents adequately. Residency funding is somewhat dependent on ACGME, but not totally. It comes from Medicare. It assumes you're going to take care of Medicare beneficiaries. It is based on caps and location. New York City gets a lot more money and a lot more residency spots. That's due to age-old Congress problems. It's usually given to an institution, and how a chair may get it is highly variable. It's at the discretion of the government, people need to understand. And there has been a move to decrease the amount of funding for specialties and put more towards primary care, general surgery, pediatrics. That's where they want the money to go. They're not really so interested anymore in funding people who are going to make a lot of money, like plastic surgeons and orthopedic surgeons. Certification, on the other hand, is ABOS again. This is individual competency, and it has nothing to do with the ACGME, although we try to work together. I've been on both, now the RC and the ABOS, and we do work together to a certain extent, but we are separate. And it too is established to protect and reassure the public. The primary stakeholder is the public, not the medical profession. But things have changed. So patient safety is a big buzzword. I don't know how many millions of errors are quoted each year in this country. Some of them true, some not. But that's changed a lot of things. The government would like to treat it as like pilots, that you can simulate things and then you're accredited. With that comes mandatory retirement. Funding issues and priorities are always an issue for us. Accreditation has changed, certifications changed, and to a certain extent, surgeon behavior has changed. So that's been both positive and negative, I would say, as far as surgeons' adaptation to these changes. Traditional surgery training, I don't know if Dr. Patakis is on the line, but I went to Dr. Hoffer and he told me orthopedics wasn't for me. But if I spent a month at LA County, and came back and liked it, he would take me, which was really nice of him. But it was experience-based, and there was no place like LA County I didn't think that was an experience-based training and education program. It actually had the operating theater there, which was unique, I would say. But we used textbooks and journals, and it was a classic see one, do one, teach one, or sometimes do one, learn one, teach one, sort of variations on that theme. But everything changed. And I pull out this picture to show that nobody's looking at that wound except one individual. Everybody's looking at cameras, and the room is dark. So that's a lot different than it used to be. It's very hard to assist on this operation. It's very hard to help. It's hard to learn how to do it if you're not actually doing it. So current surgery education is largely still remains experience-based, although the challenge is they don't get the experience. It's wiki-based. They don't use textbooks. There's very little reason to memorize the brachial plexus when you can look it up on your cell phone. There's a lot of observation that goes on, a lot of people in the operating room, and a lot of hands around things. A lot of assisting, probably a little less performing surgery, and a lot of supervision. A lot more supervision than used to be. What happened? Well, the supervision requirements were always there, but they're currently being enforced. Hospitals, largely because of liability, do not want to allow residents to operate on their own. There's also been a privatization of patients. Used to be patients were admitted to a hospital, the residents would take care of them, be their primary caregiver. Now everyone has to identify with an attending surgeon. There's a lot of outpatient surgery, where in the old days you could admit somebody a week before a total hip, get to know them a little bit, get to know their medical problems, get their dental fixed up, get their hair cut, get all that stuff done, and then get the hip done. Now those patients are in and out quite quickly. There's a lot of intensification of hospitals. People are sicker. There's generation difference, and the 8-hour work week has certainly had an impact. So let's talk about supervision requirements. Well, The reason for its public well-being is the report. Again, the IOM has been very vociferous about the number of mistakes that are made. My brother Tom's on the call. He's involved with that a lot. Medical liability, hospitals and medical centers, it's very costly. I work in Cook County, and it's one of the most expensive places to work from a liability and malpractice standpoint. The ACGME has always wanted to put in this word direct supervision, which has been fended off so far. Because you can imagine there's really no reason for direct supervision of all activity. But the American College of Surgeons has, I'm getting a little feedback there. The American College of Surgeons has requested that surgeons stay in the room for the entire time, which you can imagine with our history of overlapping surgery is a bit of a problem, or staggered surgery, I should say. And this came up in Mass General about 3-4 years ago, and it's still not completely solved. But ACS has come out pretty strongly for the real policies on consenting patients who are going to have any sort of time overlap in the operation with another patient. But certainly efficiencies required by orthopedic surgery are different than general surgery, but it puts a stress on the educational environment, certainly. Privatization of patients. You have a right to go to Cook County Hospital. You know, that was a great place to learn, as most county hospitals were, but unfortunately most of those county hospitals are now gone. What we have now are academic medical centers who want to have the notoriety and have famous surgeons to compete with those in private practice or those in the community or people with big names. That did not used to be the case quite so much. Patients more complex, I would say, at academic medical centers. I hear the word a lot, accelerated care or elevated care. It results in a lot of things being transferred out. Incentive-based comp, which we are on here at Northwestern and most academic faculty are on now, has resulted in more cases being done by the faculty and certainly has been a challenge for education. And the last thing, and I think it takes a lot of time for all of us, I bet, is the informed patient. The patient's been online and learned all about their disease and how it should be treated and really wants you to know how to treat it and use the Mako robot and everything else that they need. It takes you half your time to talk them off the shelf and tell them what you'd really like to do with them. But informed patients also don't want residents involved in their care and don't want fellows involved in their care. Outpatient surgery is an extremely limited opportunity to learn unless you're doing it. You don't get to know the patients. It's hard to work them up there, in and out. With the emphasis on efficiency, it's not a good place for a learner. It's high-tech, minimally invasive, limited access for assistance. But more than anything, it's very limited pre-op and post-op interaction with patients to actually get to know, A, who deserves an operation, and B, who does well with an operation. Inpatient intensification. So the patients who are in the ICU now were dead when I was a resident, and the patients on the floor were in the ICU when I was a resident. Everything is accelerated. Patients are really sick in the ICU. It's interesting to me why we still have our PG-1s in the ICU, because all they end up doing is working on the computer. It's a very intolerant area of learners. It used to be a place where you could do central lines and do some procedures. That's no longer the case. We use the line PG-1 has become sort of a computer drone and a consult decoy. Generational differences have certainly played some role. Residents of this generation and young people in general have different expectations than we had. You're seeing it now in the sort of cultural revolution we're experiencing. They learn and work differently, and it sometimes conflicts with what we think they should be doing. And particularly, they're capable of multitasking where we're not necessarily. So they can do several things at once, but we think that they're ignoring us when in fact they're paying attention. But the one hallmark, I would say, of the younger generation is they're very intolerant of intimidation, humiliation, abuse. Rightly so, but as that was a feature of my resident education, it does challenge you, because unfortunately, all the theories around learning suggest that you have to feel bad for not knowing something. And whether that comes externally or internally is different for different people. But you certainly at times have to feel bad that you don't know something, and that drives you to go learn it. And that's something that you just have to approach differently, I would say, with this generation. Work hour restrictions had a major effect, but now we're 20 years in. We should have figured this out. It's hard to say residents should work more than 80 hours a week, but certainly many of us work more than 80 hours a week. The Institute of Medicine actually came out and said everybody should take a nap at 16 hours. Those of you who slept in hospitals know that's not a good thing. So fortunately, we are ignoring those rules largely. A lot of the faculty resent the 8-hour work week. I'm not sure why, but every survey we do shows that faculty feel that it has interfered with their ability to teach residents. It has had no effect on operative volumes. In fact, the operative volumes that are logged year over year are increasing. Whether that's due to better documentation, I'm not sure, but it certainly is not cut into the operation, which tells me one thing, that what these people are doing is skipping clinic, basically. It's not seeing the preoperative evaluation or post-operative evaluation of patients, but getting in the operating room. It certainly has increased the role of physician extenders. I'm sure you have many. We hire probably 2 to 3 APPs for every MD we're hiring. It's tremendously increased that role. But how do they play with the residents? How does that affect the resident experience? Is something that people have not really looked at in any sort of close way. So we've got a little bit of a perfect storm. We've got more than ever to learn because orthopedics continues to grow exponentially year over year. There's less opportunity to learn it, less time. Faculty are challenged because they need to generate RVUs in business. There's a focus, I would say, on techniques over indications. And we have very bad assessment tools and feedback. So it's hard to make the system more efficient. In the next section, I'm going to talk a little bit about how we're going to try to do that, I would say, in the next 10 years. What is clear, though, is experiential learning, as far as being able to do things on your own, is in critical condition. You're not going to be capable in an 80-hour work week of learning everything you need to learn. You do need learning objectives. You need to know what to know. Like some football players I knew at Modern Day, they just want to know what was on the test. I need to know what to know. They need a list of essential skills, what to do. We need to define what those skills are. We need to know what a graduating resident's capable of doing when they graduate. When we hire them, that we haven't hired somebody who's not able to do things. And we need reliable formative tools to help them along the way to assess that competency. And the last part is we do need to allow them to learn some independence, which gets back to the tolerance of error issue a bit. What has not changed the purpose of residency is the education of allowing one to safely practice orthopedic surgery independently, which is what I have to sign off on every resident that leaves the program. In my mind, that means they're capable, that they're responsible, and that they're collegial and work well with others. The department hasn't changed either. We want to treat the most challenging problems. We want to educate because we feel we have a societal obligation to teach the next generation and replace ourselves. And then research, discovery, clinical analysis. Just like your institute, the same issues I see on your mission statement there, clinical literature, and then research, discovery, clinical analysis. Just like your institute, the same issues I see on your. Okay, so what are the practical solutions? Well, we recruit the most intelligent and hardworking individuals. It takes us 5 years to dumb them down, or as my friend Rex Hayden says, negative alchemy. But we hire the best and brightest out of medical school. There's a patchwork of workarounds. We have night float rotations, which are sort of nonsense if you think about it. We add months and skills to the PG 1 year. So now they're doing a lot of orthopedics their first year, and there are required skills that they have to acquire. We're extending the training program. Virtually everyone does a fellowship, and at least 40% are doing 2 fellowships. So we're extending that education process between 6 to 7 years now. And then we have people who super specialize. Some people choose to super specialize as PGY3s, and no longer want to do PEDS or other things. But if we super specialize, it's easier to get it in a shorter amount of time. So those are the current solutions. Are the best thing? I doubt it. But that's what's currently going on. These are just a little bit of a dated slide, but it's still true. In 2016, 2020 is the same. Everybody's NBME scores are going up. Those that get into ortho, those that go into other fields, those that don't get into ortho. Year over year, the board score performance increases, which to me says that the board scores are not really very helpful anymore. And as of this year, next year, they will no longer be scored as far as the number of pass fail, which I think will be a positive thing. When we look at FAOA or honor societies, which are under some challenge now, you look at orthopedics, of course, we're way overrepresented, right? Dermatology and orthopedics. The poor people taking care of your children, Bob, if you're on the line, don't say anything, Lisa. Pediatrics, look where they are. The best and brightest are going into these fields, largely, I would say, because ability to do technical procedures, and to generate a very nice lifestyle for yourself. So we do get the best and the brightest because it's a good field to be in. It's a challenging field to be in. But some of the general fields do not get the same level of talent as far as the honor societies go. This was the average Ortho PG1 in 2015, and this would be good for a junior faculty member of mine. MCAT scores were 32, board scores out through the roof. They had 3 research issues, and most of them had, on average, 6 abstracts, presentations, or publications. So this is your medical student coming out of the 3rd year, going into the application process. So these people are very accomplished, and they know what to do to check the boxes to get in. We are getting the best and brightest. Fellowships are very similar, I would say. This is the 2020 match data from adult reconstruction, and you've got 4 fellows, I think. Right? So 230 applications, 189 matched, okay? So there are some spots that are not going to fill necessarily, and they're all very competitive. We've got a lot of good people in the pipeline wanting to do these things. But if you can reimagine education, if we could start from scratch, we probably would not do it the way that we currently do it. First, we would probably change the criteria for resident recruitment away from test performance and more into human qualities, more, as you can measure, grit, resilience, those sorts of things that we think are important to make a good doctor and to make a good partner in the future. We would probably de-emphasize time in education and count more on achievements and the ability to hit certain milestones. We would certainly moderate service expectations as far as, just standing there and holding sticks on a 20-hour spine fusion. Is that really valuable after your 3rd one? I don't know. I doubt it personally. We would understand what the product of the residency ought to look like, and then what the knowledge and skills are to get to that product. We've never really defined what the product needs to be. We would document the achievements in some way, and you can do it in a variety of ways. Competency-based education is coming. It has already hit Canada. I think it's coming here. We've already got some tools listed that are heading towards this. What is it? It's a checklist of goals and objectives. Not really. It's more formative than that. But essentially, achievements have to be made during a residency to allow you to be promoted and allow you to get out and to take your boards. It's modeled on other technical fields, but it requires periodic assessment, determination, and competency as you go along. It's highly efficient. It's highly focused on the resident. There's a lot of documentation to see if they met or not met the requirements. It's very hard to exit a resident without this sort of documentation. It standardizes their experience. You know what the product of the residency will be. And in Toronto, it's done very well. People finished actually a little bit early, which is a little unfortunate because they have a little unemployment problem with orthopedic surgeons in Canada. It is an administrative nightmare. It's hard to get consensus. It's very costly. You need assessment tools. You need some continuity of care. And the faculty, there's a lot of demands on the faculty and competency-based. So that's the downside of it. There's a lot of hazards, though. If we don't take charge of this, we might end up in real trouble because we might lose our profession if we allow other people to make these decisions for us. So that's a big part of the reason I stay involved in this. What should an orthopedic surgeon be capable of doing? Jim Kellum, I was privileged to be part of this task force, looking at what a orthopedic surgeon be capable of doing. When you think about, as you're going to educate someone in 5 years, what they need to know and what they need to do, this was very important work. Jim did a great job, put together insurance executives, emergency room doctors, family practice doctors. What do they count on when they call for a consultation? And it was published in the journal. I can tell you what the government thinks is important: arthritis and non-traumatic joint disorders, cancer, and functional limitations, disability. So orthopedics fits in government priorities, but it fits in certain categories. And what we have to think about as we educate residents is what categories we're going to focus on. Because for public health, if you look at the government, it's trauma, infection, cancer, peds, total joints, especially total hips, and selected spine procedures. What is more challenging to argue with the government on are a lot of things we do. Probably the most common procedure we do: arthroscopy, ACL reconstructions, and shoulder reconstructions. We've got to prove the value of these as we reflect again on what we're going to educate people on as to what the government's going to reward going forward. I can tell you what the top 10 procedures are when people take their boards. This is data from part 2 of the boards. It's knee arthroscopy, shoulder arthroscopy, ACLs, the things you would think would be common. You know, these are the top 10 performed procedures for those taking part 2. The ACGME, based on that list, came up with this list of minimums for people in residency to do. And you can see a lot are understated. So they're going to do more than 30 knee arthroscopies as a resident. But that wasn't to be overemphasized. But this was sort of the minimum experience that the ACGME requires. In other words, to have that sort of field where someone could actually get the education they need as a measure. Additional procedures for reductions of fractures, foot and ankle arthrodeses. I argued against tumor at all, but they put 5 biopsies of prophylactic fixation in, and the supraclavicular humerus was from our pediatric orthopedic colleagues. And this is the data the ACGME looks at when it looks at residency programs. And basically on the left is the number of procedures that a graduating resident reports after 5 years. And each of those dots is an individual resident. So you can see most programs on average there are doing about 75 to 80, I think this is total hips, in the average program. Some programs are doing 160 plus. That's probably a program that overemphasizes adult reconstruction, right? But who wants to be in the program down that bottom 10 percentile? It's only doing 30 or 20 or 10 or 8. That's the kind of program that needs some work. It needs to have more either affiliates associated with it, or it has to be closed, right? It has to, it doesn't have the number of patients, the number of procedures that you can have somebody who's actually good at things when they leave. Fellowship, you're seeing this now, required procedures. Our fellow has to keep required procedures. The problem with this sort of logging cases doesn't measure competency. No one knows if you're good at it, or if you're able to get along with other people, or if you're professional in how you behave. And all are procedural. None reflect the art of medicine. And frankly, I don't do anything. I don't think anybody more than 10 years out of practice does a lot that they did as a resident. What is needed? We need a valid assessment of essential knowledge, skills, and behaviors. We need dedicated teachers and assessors. They all don't have to be physicians. And we need the residents to regain ownership of their education. Right now, it's like you're, I don't know if you're in high school or something, that somebody's telling you what to do all the time. And if it doesn't happen, it's the program director's fault or program coordinator's fault. Residents and adults at this point, they need to own their education. And if they're not getting what they need out of it, they need the capability and to take the responsibility to get it. So the vision of the board anyway, and I think this is true of most medical educators, including the EMA, is, you start out sort of a novice and then you move to become a master. Well, that master occurs, I think Carlos told me, about 7 years of practice. I'm still waiting for it, but it takes a while. But the GME part, your residency and your fellowship is right there in the middle. And hopefully you don't leave your residency before you're competent. And hopefully you gain some proficiency in this. But what do you need to know? How are you going to measure this and how are you going to know it is what we're trying to work on now. So the vision and what we've done at the board is this just a bad example. But you think about your life, your professional life, in 3 broad categories. One is your medical knowledge. The second is patient care skills, okay, how you actually can do things. And the last is behavior. Again, most of our problems in practice, most of the issues of the board have to do with behavior, not with skills or knowledge. But in any case, what we would do is do assessments in each of these throughout your 5 years, and then designate certain levels based on normative behavior as to where you end up. And the goal would be, when you finish your 5th year of residency, that the residency program director and chair can sign that statement at the bottom saying that you certified the resident meets the content accreditation requirements to independently practice orthopedic surgery. Right now, there's no way to do this. There's no documentation. We do it based on what we feel about someone, and it's very hard not to put somebody through. That's a problem. So we'd like to actually have something to document. This is just another graphic of the same thing, essentially. What you do notice is knowledge does go up each year. It tends to tail off between year 4 and 5. Skills and assessments do get better every year. Behavior, it's very fascinating. It is level. You pretty much come in with the same behaviors you leave as. It's a little like Fulton Sheen said, even Jesus picked one bad one out of 12. You don't change your behavior that much as a resident. So if you have ethical issues or interaction problems in year 1 and 2, you're probably going to keep having those in year 3 and 4. On that, you can make a decision whether or not orthopedics is in their future. So ideally, it would be a valid measure of knowledge that we would use. We are working with the academy now on the in-training. We are incorporating board questions into the in-training so that we can get some normative data so that we can have actually a passing standard of the in-training rather than just giving a percentile rank. That you would have to meet a certain level to go year to year in orthopedic residency based on a sort of invigorated OITE, if you will. The next thing is skills. We got this tool. We've got a great IT guy that works with us. Basically, the resident puts in a case that they do. They try to tell the attending before the case they're going to be evaluated on it. It takes less than 2 minutes to fill this out if you're a faculty member. It's on your phone. It's very quick to do, and it can be dictated. They get immediate feedback, and they know exactly where they are. It's really a really nice system. We've been using it here for 2 years. It's well received. Again, the resident has to own their education, though. They have to request it. But it's not a big labor or big problem for faculty. And I would imagine in your fellowship, you could do the same thing. It would help them move along, and it helps you case by case to tell them what they did well, what they didn't do so well, what they could do better the next time. And I think you'd find your fellows move through the program a lot faster. This is the tool we use. There's 8 subgroups. I know it looks a little overwhelming, but it's actually very easy to use. We did a couple surveys of people and 1 study around it. It was well liked. It was well used by all parties. And I think it gets to the 8 features of what goes on around an operation. It's based on some work out of Ottawa. That's why it's the O-Tool. It's not an Irish pub across the street, but it's close. So, but these are the handles that you would use. Like, if, some residents, you had to do it. Some you had to talk them through. Some you had to prompt from time to time. 4, you need to be around just in case. And last, you really didn't need to be there. So we would love to have all our PGY 5s on key procedures to be at a level 5. That would be ideal. This is the P tool. The residency program directors wanted this tool in addition, just to give them an absolute grade at the end. So these are the standard sort of adult learning grades. Again, we want people to be competent. These are the examples, some research we did with 16 orthopedic programs across the country, and you can see there is an improvement year to year. So this appears to be a valid tool in measuring skills in the operating room. This is published in JBJS. And then we said, what cases should we look at? So we do have this log data, and don't bother looking at the bottom because I'm going to go this high focus. These are very frequent procedures that are done across the country. And these are the ones we think residents ought to be good at before they leave. Okay. There may be some discussion about, here or there, maybe, but all these things, I would say the graduating residents should be competent to do independently before they leave. So these are the ones we're going to target. The mid-range cases, you can pick and choose probably from this, and each specialty has now chosen the procedures that they think are really key to do and those that are more optional that they should observe. And then these rare cases, like the things that I do, or believe it or not, below-knee amputations are in this list. Maybe we don't need to measure those quite so adamantly throughout their process, because these are probably less important for the graduating orthopedic surgeon. So this is 2 examples, upper extremity and pediatrics. These are thought to be key procedures that residents have to be good at by the time they finish their residency. Demonstrates competence means they have to be able to do it independently. Adequate exposure means they have to be able to do it with some help, or they have to see enough of it. They have to be involved in it. Because a lot of people don't feel comfortable with supracondylar humerus fractures. It makes people nervous. The third thing is behavior. So we did design this behavior tool. April Armstrong led the path here, and it's really very nice. Again, very easy to do. That they adhere to ethical principles, that they communicate, that they interact with other people, they're reliable, which is a big issue actually, and they're committed to autonomous maintenance, continuous improvement. So this has different handles as well. We're not getting too busy. This similarly is a iPhone tool or a phone tool that's really easy. The handles are good, and we can send this to nurses. We can send it to operating room nurses. We can send it to their other residents, so that we get this sort of 360 measurement of how people are doing. And this is as easy as it gets on your phone. And it has handles below so that you can measure what you think. And you can imagine in your practice, you've got partners where you would sort of assess each other, maybe positive, maybe not so positive, I guess. This leads to the sort of dashboard that a resident would have. They would know where they stand. The program director knows where they stand, and they know where they need to improve. Okay, so we can fix perhaps something. These are two residents that we did examine in the past, 2 years ago, I guess. These are scores that they received, and you can see how most people are going to get by on this. And again, they're not going to improve from year 1 to 5. If you're unethical, you're probably unethical from year 1 to 5. But there's some red bars on this John Doe character, and you're going to have to address why that might be and to see if it improves. Again, if it's persistent, then that person may not necessarily should be an orthopedic surgeon. I'm going to wrap up just by saying transition is likely. We're going to refine the assessment of essential knowledge, skills, and behaviors. I think residency will be condensed. There'll be a lot of large regional tools, like in Chicago, we have 5 residencies. We will probably do some things together around simulation, which is key to learning a procedure. And there'll be a lot of alternatives, I would say, to rotation-based residents. And it's going to be a hybrid model. There'll be some service, but it's going to be reduced compared to the teaching that goes on for the residents, at least I would say in the major academic centers. It's essentially lead. I'm told a lot because I'm at the table that I was involved. If the decision is made before I get there, clearly I was not involved, but I think we do need to lead this as a profession. And I like this quote: money is not going to make a difference. So money, nor technologies, nor administrative controls prove an effective surrogate for the commitment to integrity of the profession. So, we're not going to get around this with money or technology or control. It's got to be innate. It's got to come from the profession. We've got to take care of the next generation. So, finishing, you still got the best job in the world. We're all dinosaurs. I've got great patients, great residents and colleagues. The Chicago 5, prior to Dr. Schaefer passed away a year and a half ago. Those are all the orthopedic programs in Chicago. And I really appreciate the opportunity to talk to my home. I'll take any questions or comments you have. Thank you very much.